welcome back to another episode of Coffee with Coker. My name is Mark Reibold, and I'm the host. And in case you don't know, if this is your first time listening, Coffee with Coker is a podcast that's published by the Coker Group. Our focus is discussing topics and issues in the healthcare industry, specifically around helping healthcare organizations navigate this changing landscape going on in the healthcare industry today. And so today we have another great conversation, actually put together a kind of a roundtable discussion with a few of the team members from the Coker office. And this is also going to be a kind of an initial episode that's kicking off a series that will cover various topics related to physician compensation. And so in this episode, this is kind of the physician compensation roundtable. We have Justin Chamblee, who is the Senior Vice President at Coker and heads up Coker's Physician Comp Services. We also have Stephen Ross and John Morse, both team members here in the comp group. And what we wanted to do here was, again, kick off this conversation around physician comp and just broadly cover some of the various topics, issues, different subjects related to comp. And so we cover a lot of different things, but I thought between Justin, Stephen, and John, they had some great feedback. And also we had the opportunity to tee up a number of other issues and topics where we absolutely are planning to come back around and have follow-up episodes where we can talk more specifically into some of these things related to physician comp. So again, I think it's a great discussion, and I encourage you all to continue to check back, stay up to speed with us on social media, and we'll be sure to let you know as we have more discussion available out there on this subject, as well as a number of other topics. So with that, please enjoy this conversation with Justin, Stephen, and John. Today, we got a great group here, actually, so it's something new for us. Kind of what we put together is our physician compensation roundtable, if you will. And so we're talking, obviously, about physician compensation, but we have what I would say are some of the experts within Coker and some individuals that have become experts really throughout the nation in terms of working with hospitals, health systems, physician practices as it relates to physician compensation and just related issues. And so we have some different perspectives real quick, and I'm just going to go kind of around the table here and let everybody quickly introduce themselves, give a quick blurb, kind of what you do, and then we can jump right into the topic. So here to my right, we'll start with Stephen.
My name is Stephen Ross, and I've joined Coker 2 years ago now. Prior to joining Coker, I worked in the industry, in health systems and hospitals, in practice management, both operationally and in various leadership roles, merger acquisitions, managing physician compensation plans, working with health system on setting up governance and related matters. And it's been a privilege for me to work alongside of the rest of the panel that will be introduced shortly, and also provide some insight into the practical application of compensation within health systems and medical practices.
Great. Yeah, this is Justin Chamblee. I'm the next in line, if you will. I've been with Coker for about 12 years, senior vice president, and really spend all of my time working with physician compensation, both on the strategy side and the valuation side, and really looking forward to sharing some of the insights with you today.
And hello, I'm John Morris. I'm here in the Atlanta office today, usually dialing in remote from Grand Rapids, Michigan. I have been with Coker for 4 years and work with Justin and Stephen on all of our compensation design and valuation projects. And I'm looking forward to a great discussion today.
Yeah, it's nice to have John here in the office when we can get him in. And this is actually a great group, and it's one of those topics that whether or not you want to argue if it's the most exciting in the world, you can't deny the fact that it's obviously very relevant to our client base, to our marketplace, and it's something where we have done for many years and still today do more and more as it relates to client services around this topic. And it's a topic that's expanded. So what we're going to try to do is we're going to cover it pretty broadly, honestly. We're going to cover some high level viewpoints and perspectives on some of the key trends and issues related to comp. And then, of course, this is a part of a series that we'll have follow-up episodes and discussions where we drill into some of these in more detail. So I just want to let everybody know that. So they can kind of stay tuned for, if they have follow-up questions or want to hear more about one of the things we discussed. But I guess the best place to start, and I'll throw this out to the group, whoever wants to jump in, but let's just kind of tee up the issue, starting with, I guess, current trends, where we are today with physician comp, and I guess, what do we mean when we're talking generally about physician compensation?
This is Justin. I'll speak to sort of the two key areas that I think we spend most of our time dealing with right now, and I'd love for Jon and Stephen to comment on this a little bit more. But if I have to boil it down, I would say the first core issue is affordability, meaning can we afford what we have put in place, whether that was last year or 5 years ago? And obviously, there's a lot of pressure from a reimbursement and cost standpoint in the industry, and ultimately that makes us look at what we're spending on physician compensation and making sure that the ends can still meet. So that's the first item. The second,
and Justin, sorry to interrupt you.
No,
but
sure.
When you say can we afford, you're kind of putting yourself in the perspective of, say, a hospital or health system, right? And you're looking at, we're employing physicians, we are doing alignment ventures or joint ventures with physicians. Is that correct?
Absolutely. So talking more so on the employment side of the equation, and there's a lot of talk surrounding the investment per physician. And what we find is either health systems aren't aware of what their investment or loss is per physician, or they are finally realizing it and it's growing. And they step back and they say, okay, what are the drivers of that? And is that something that we can tolerate long term? So, and I'll come back to that because I'd love for Jon and Stephen to provide their input and insight based on the clients they've worked with on that matter. But the other is really a structural or a design related focus. And that is with all the pressure to move reimbursement from pure volume to a value-based play, how is that affecting how we go about compensating physicians from a design standpoint? So it's working with clients all across the country to look at what's going on in their market and help them design models that perhaps are better aligned with the reimbursement. So Jon, Stephen, I don't know if you want to add to that and maybe provide some specific experience as to what you're seeing.
I know from my work with various clients in industry relative to compensation plans, one of the big points that is frequently discussed at the administrative level is how can we organize all of our physicians, our compensation plans, so we're all in the same boat rowing together. And I think you alluded to that, Justin, with respect to value-based strategies, but also things such as what's important in terms of quality, what's important in terms of patient satisfaction, what's important in terms of stewardship or citizenship. So instead of just showing up to punch a clock, how can we empower physicians to really be part of a team and drive the care process instead of just sort of check out in that kind of strategic management perspective? And so that's definitely a consideration when putting together compensation plans, is ensuring that there's alignment with the overarching vision for, be it the medical group or the health system, to make sure that all of the components, if you will, all of the business units are rowing in the same direction, and we've got engagement, physician engagement throughout, and ultimately advanced practitioner engagement as well with those various strategies.
Yeah, I think a couple of things you mentioned there are really interesting to me, in that I guess first, it's more than purely economics, obviously, and we'll talk more about fair market value and commercially reasonableness here in a minute. But there are other elements to it, non-economic, I guess, if you want to put it that way. I want to drill down a little bit further on, okay, what do these plans look like? And then, once the deal is done, how do you manage them in a way that is accretive, that is supporting growth and continues to be maintained in a positive capacity going forward over time? Because we know just when it's done, that doesn't mean that's it. And then the other piece there, the other kind of buzzword I'm glad you mentioned, we just did another episode previously with Amy Creeder and Taylor Harrison, specifically on physician engagement. And that was part of the discussion. How do you get them engaged? How do you keep them engaged? And that ties directly back to economic incentives and non-economic, obviously. So I think those are some good points.
Yeah, I mean, I echo all of that commentary. And also from an affordability standpoint, I think, you always have to kind of start with a bigger picture. I like to put my clients through what I call the fact finder. Just go through from the starting point and take a look at all the different factors they have, both quantitative and qualitative, because I mean, especially in rural markets and in some inner city markets too, you get situations where affordability might be kind of back of mind, and the biggest issues they have are retention and recruiting, just trying to get people there, physicians there with the skills that they're looking for to serve the needs of their community. And you have to be able to find a way to tie that into what you're actually designing and putting forward. But, I think that ultimately, more than I've experienced previously, we're dealing with those issues of taking a very hard look at a large financial review at the beginning of any of these projects and really getting to know the ins and outs of their financial situation, what's really happening in reimbursement in their market, and what's actually happening with all their different costs. And the largest costs are usually labor.
And I want to come back to two things on design, something that both Stephen touched on and then Jon touched on. And the first is what we see is that the design question, there's not a one-size-fits-all solution. I know, Jon, you've been working recently on a client in Ohio, and it's a small town, critical access hospital. Yeah. And as you mentioned there, the guarantee element is a very important piece. And so we structure the comp arrangement to perhaps promote retention and recruitment more than anything. So affordability, yes, it's important, but it's perhaps a secondary issue, because if we don't have physicians, we can't serve the population. Whereas if we're in a large urban environment, the design element may look completely different. And so we've got to cater the design aspect to what's going on in that particular market. The other thing that Stephen mentioned is just almost the governance element of compensation going forward, and the fact that we need all the physicians marching to the beat of the same drum. And I've used the analogy before that physician groups are comprised of sort of a slow build, meaning we go out and we find a local general surgery practice that we purchase and we bring in. Then we recruit in a bunch of family medicine physicians. Then we hire another group of doctors in the market. And, after about an 18-month period, we step back and we've got a medical group of 200 physicians. And they're all happening to be on a different compensation arrangement, or at least multiple different models. It's not a situation where we wake up one day and we say, you know what, we want to go hire 200 physicians. Here's the perfect model, and we're going to make every single physician adhere only to that model. That's not reality. And so what we see a lot of health systems struggling with is taking all the deals that they've done over a 12 to 24 month period, and then trying to bring all of those together to make sense of them and wrap them into a single cohesive compensation strategy. And what we find is, furthering the design process, meaning moving into value-based elements, things akin to that. If you're managing multiple deals versus a compensation strategy, you're going to be woefully behind the eight ball, or at least just dealing with so much administrative mess and chaos that it's going to be hard to really push the ball forward. So I think, and we could spend a whole session just on comp plan governance, but I think having that single strategy, that single methodology that all of the physicians in the medical group are marching behind is so important to being able to be adaptive to the environment that we find ourselves in.
Yeah, that's a great point. And actually, I'm glad you brought it up, because I do want to circle back to what are some of the variables that you have to kind of think about and continue dealing with after all those deals are done and you get through a few of them. Real quick, I want to transition just briefly. In all of the comp work we do and much of the transaction work that we do at Coker, particularly hospital physician transactions, there's a comp element to all of them, obviously. And whether we're designing a plan, developing that strategy like you talk about, Justin, or if we're doing a deal for a hospital per se, and we're having to deal with kind of how do we value compensation, how do we value this transaction. So I want to talk about valuation for a second, but before we do that, I feel like we almost need to start talking about how we measure and ultimately calibrate compensation, market-based compensation, which ties into fair market value, obviously, which we can talk about as well. But maybe just briefly cover, how is some of this measured? How do we determine fair market value? And then, tell us about kind of some of the resources such as the surveys and benchmarks and market data that's used in order to determine that.
Sure. We typically use a combination of 3 surveys, and we take an average of the national benchmarks from the MGMA, Medical Group Management Association, AMGA, American Medical Group Association, and the Sullivan Cotter and Associates Physician Compensation and Production Surveys. And we tend to use national numbers for the majority of the work that we do, mostly because I think the reason we get this all the time, the physicians saying, well, I want to use this doesn't reflect what we're really doing. And we really view physicians as kind of a national market. I think they're one of the most mobile of all professions, really. I mean, they can go just about anywhere. But the national numbers are much more reliable in the sense that you get a larger sample size. When you're trying to create a compensation strategy, they have a lot less variance. So we use a combination of those surveys. You typically focus on the national benchmarks. And then we, if necessary, adjust them down or, maybe use a little less or a little more depending on what market we're in. Some of those rural markets, when you're talking about fair market value, it's completely different than when you're in, a major metropolitan area. I mean, and a lot of that just has to do with basic supply and demand. Everybody wants, when they graduate and they're young, to live in a big city with lots of amenities. And, when you have a huge supply of doctors there, I mean, you can typically pay a little less for them and have easier call schedules and the like. When you're out in a very small town in rural Texas or Kentucky or Ohio, I mean, you typically have a larger call obligation, less people in the rotation, and there are obvious benefits to living out in rural communities too, but you tend to not have all the big city amenities that you might otherwise have. So, I mean, I think in instances like that, we change our view on what is fair market value and take all those different factors into consideration. And then commercial reasonableness is increasingly, I think, important as well, and really being able to document those reasons. And I think it's just increasingly important, especially for the hospitals, to document that internally. When they face these recruiting and retention issues, write it down, put it in a folder. When you get your employed physicians going out and saying, well, I got an offer from so-and-so down the road for this much more. I mean, why am I not getting that much? Say, okay, show them in the offer letter. Bring it in. Let me see how much they're offering to pay you. Or
what are the other terms that
exactly
may be involved?
Yeah, I mean, all of that stuff, in my opinion, is a way to document what it really costs to do business in your market, which I think is a main factor for supporting what you have to pay.
Yeah, I mean, two great anecdotes from what Jon just mentioned. I mean, I could probably spend hours just dissecting what you just talked about, but I'll try to keep it brief. I mean, I had a client the other day. It's in the Midwest region, in a urban environment, and the entity that they were negotiating with wanted to use Midwest data. And when he looked at the Midwest data, it was for a surgical specialty. Pretty nuanced surgical specialty. The respondent sample size in the national data wasn't great. Midwest data was even lower, but the Midwest data was 30% more of the median. I mean, why wouldn't you want to use that? And so what we went and did using MGMA, because it's really the only survey where, at least with the tools that we have, you can go in and break it down by state. We went and showed them that, hey, the majority of respondents are all coming from states outside of the state that we're dealing with. And there is a specific state that is inflating the data. And so what we basically showed them is the idea of using Midwest data is great if that data is representative of the specific market you're in, but it's not. And so from our vantage point, the national data in that instance is better, i.e. due to the higher respondent sample sizes, et cetera, than the Midwest data. But, you don't understand that, you don't glean that if you're just using it from a super high level. And the other key point that I want to touch on is Jon was mentioning sort of the idea of interpreting the data and understanding all the other terms. Similarly, we were working with a client in Ohio who was trying to recruit a certain surgical specialty, and they were having intense pressure from their local competitors because of perceived gaps in salary. And we're talking like, 30, 40, 50% gaps in salary levels. And instead of taking the data that we were getting at face value, we said, let's dig into it a little bit more. And what we found is the one hospital that they were comparing to was requiring 40-50% more hours of work to receive those higher levels of compensation than what they were offering. And so when you looked at it on a per shift basis, it was actually identical, if not higher. And so it's one of those, when we are starting to talk about market data and comparability, we truly have to make sure we understand all of the dynamics in play, meaning looking at just a total cash compensation number is not sufficient. We need to understand what is the work requirement associated with that, whether that's measured in production, i.e. work RVUs, or time, whatever it may be. And so really digging into those details is so important. The last thing, and I'm going to tee Stephen up to talk on this, is the affordability aspect. Because when we get into talking about survey data and benchmark data, affordability, I think, comes into the equation very much so. And we've had so many clients come to us saying, hey, the benchmark data keeps increasing. How can we afford this? And what we always say is the benchmark data is a good starting point, but not the end-all be-all. And I know, Stephen, we recently worked on a client where this specific matter came up. Maybe you can speak to that, because I think it'll provide some real-world evidence of how this is manifesting itself.
Absolutely. So when we look at survey data, just because there's a value at a certain benchmark percentile point, say median or other, that doesn't necessarily mean that that's where a physician should be paid necessarily. Rather, after understanding what those kind of the national environment looks like, a health system, a hospital, a physician group really needs to take a step back to say, okay, what are the local dynamics? What is our local payer mix? What's our local demand? Much like Justin said, what is our local expectation for coverage, et cetera? What is included then maybe stacked on top of in terms of call pay or at other administrative pay, et cetera, that should be taken into consideration. And so instead of starting at local and sort of building up, we take more of the approach that we start at the higher level of national and kind of drill down to sort of customize for our needed clients. And simply because a physician or a survey says that you could pay doesn't necessarily mean that in that instance you should pay a certain level of compensation. Rather, it really needs to be considered through the affordability lens as to what can be, what is fair for that locale.
Right. So I think what we find ourselves doing is breaking apart the comp components and making sure we understand all the elements, but then also looking at what the health system or the medical group, whatever it may be, is collecting per work RVU, right, so that then we can correlate the two. Because if you're paying out, to use a very simple example, $60 per work RVU, and you're only collecting $70 per work RVU, the gap is pretty small in terms of what we have to cover for overhead and benefits, malpractice, et cetera. And so I think what we find is when we start breaking down what health systems or medical groups are collecting per work RVU versus what they're paying out per work RVU, it's providing sort of another lens through which to look at the benchmark data and make sure that we can afford what we're putting into place. Because it's always easier to set something out the onset and then ratchet it up versus set something and then have to ratchet it down. So we'd always rather start conservatively versus liberally.
Absolutely.
Yeah, and I think that this just goes to show there's an incredible nuance to the discussion around surveys, benchmarks, and that and all that goes with that, which we are going to come back around in a future discussion and where we just talk about this stuff, because I think, well, I know we get an incredible amount of questions that come both from our clients and others. And of course, we do a lot of work around this. So I think we have an opportunity to answer and address a lot of those questions. I do want to talk about how this flows into, so you've done the comp design or the broader strategic development of the comp plans, or maybe you've done a deal where you're employing a group of physicians. Now let's talk about kind of the compliance angle. We do, and our comp group does a large degree of comp valuation work or kind of compliance related work. So let's talk for a second, just quickly maybe define and give a broad overview of what is fair market value and commercially reasonableness, and why are they relevant to this broader discussion?
Yeah, sure. I mean, I think fair market value, if you look at it, is a requirement for pretty much any exception as relates to the Stark Law or anti-kickback statute. So, to use a great example, when a health system is going out and employing a physician, typically they are meeting the employment exception. And one of the exceptions or the stipulations of the employment exception is that the arrangement is both fair market value and commercially reasonable. And fair market value, for a lack of better terms, is basically the value that would be paid to a provider, if you will, in the absence of referrals, meaning it can't be influenced by referrals. It has to be what the market would dictate for the actual work that the physician is performing. And as we think about that, that's really what we're looking at through the lens, or looking at the compensation arrangement through the lens of, is what should the physician be paid for that specific set of services that they're providing. And so in order to value that, it has to be very much focused on the services and understanding what the physician is offering, whether that's production time, administrative hours, quality related metrics, et cetera, really defining the services and making sure we're valuing each of those both individually as a component, but also holistically when you add all of the sum of the total together. I want to pivot, though, and talk a little bit about commercial reasonableness because, fair market value continues to be a focus. It's been around for a long time, but we see so much more emphasis on commercial reasonableness in today's market. Not to say fair market value is not a focus, but commercial reasonableness continues to rear its head. And to define fair market value versus commercial reasonableness, fair market value is sort of the dollars and cents of the transaction, and commercial reasonableness is, does the transaction make sense in the SENSE sense? So, great way to think about commercial reasonableness and how we approach documentation is, first off, defining what the need is. And second of all, defining some objective support for that need, meaning if we're talking about pediatrics, why is pediatrics a need? What does the market say as to the need for pediatrics? And then looking at the specific transaction we're talking about and specifically documenting how that transaction meets the need in the community. Meaning if we're talking about employing or recruiting in another physician that's a pediatrician, specifically documenting first off the need, the fact that perhaps the community is underserved in the specialty of pediatrics. This physician community needs analysis shows that by us recruiting another physician, bringing them into employment, that helps to meet the need. And that kind of documentation is in essence what's needed, very objective. The key thing that we also mentioned, and I think, John, you touched on this, and you may want to speak a little bit more to it, is that we see commercial reasonableness as being sort of a three-part exercise, meaning there's an operational piece. We always recommend clients maintaining their own documentation for commercial reasonableness. We see a legal component, meaning documenting the legal element. And then as a third party, specifically with respect to the compensation being offered, we can offer our insight as well. And I think if you're approaching it from those three factors, when you put it all together, you've got a pretty robust set of documentation relative to commercial reasonableness.
I completely agree with that. And, I think one easy way for hospitals and administrators to kind of keep all of this together in a good schedule really is to set it up on an annual basis. Just make it part of your compensation governance, your strategy, essentially, to review this stuff on an annual basis, to go through your files and make sure you have documentation if you've hired new people and you had to pay a lot to get them in the door. That's just one simple and easy way to do things. And a lot of our clients do that on an annual basis already. They have some sort of, way where they review their compensation on an annual basis, making sure that everything's within fair market value. But I think taking that a step further and really making sure you have all your documentation together internally, and then whatever documentation is provided from your third-party independent evaluator is also really helpful to have.
Yeah, I mean, I know to Justin's point, kind of the three components there. I mean, anytime we're working on anything related to comp, particularly on the valuation side, we're typically working alongside legal counsel, whether it's in-house or outside. There's, obviously got to be that operational component. We're working with someone in the system that is kind of either over that or responsible for that component. Stephen, I know you've been in those shoes before. And then, obviously we've served that kind of third party function that is independent evaluator.
And I think just piggybacking on some of these great comments, I think some of the good sources that a health system hospital administrator can use are the community needs assessment. They can use their health system strategy or medical group strategy. Where do they need to grow to meet the need of the community? They can also look at access, patient access. Are there certain practices that they just can't see all the patient for which they have demands? Or are there areas that are underserved that they really need to grow? And so from an operational perspective, there's multi-pronged, if you will, sources of data that can be just compiled in, much like Jon said, documented into a file on an annual basis to demonstrate that the services we are providing vis-a-vis our physician network are truly commercially reasonable. And so those would be things that I would look at.
Yeah, that's a great point. So I want to go back. I said earlier I want to come back to talk about the process, I guess. So in thinking about a little bit in terms of maybe a continuum or kind of how that process flows, let's go back and revisit, Justin, something you talked about or kind of alluded to, and talk about the strategic comp plan design, what we mean by that, what that process can look like. I know you talked about that there's two key components. There's no one size fits all solution. And then there's, the government's element as well, which Stephen spoke to. But if we're working with clients, talk about that design process. And then also what are they thinking about, looking out for? What do they need to be thinking about and looking out for?
Yeah. So I'm going to put both Jon and Stephen on the spot and tee them up, because I think you can bifurcate the management of compensation plans into two key pieces. One is the initial design phase, meaning how do we go from where we are today to something new? And then I think the other piece of it is the ongoing maintenance phase. How do we maintain what we've developed? Because what we find is it's not a one and done process. I mean, compensation models today are living and breathing. They require a continual check-in and maintenance and tweaking to make sure that they're relevant. And so maybe, Jon, you speak a little bit to sort of the comp design process and sort of what we've experienced with different clients in terms of what works, what doesn't work in terms of going about that. And then maybe, Stephen, you can follow up and share some of your experience about best practices for comp governance on an ongoing basis.
Sure. Yeah. I think to this day, I've never been through a compensation design process that's exactly the same through and through. I think anybody who's been through it knows it. But, each organization is different, and you see a lot of similarities. And in that, I think you always start with gathering information. You try to get as much information as you can, and as much as the budget for the project allows, as much as it makes sense. I mean, if you're working with a health system that has 1,000 employed physicians, it doesn't make sense to try to interview each individual physician. But if you're working in a small community hospital in a rural area and you have 25, 30 physicians, you could probably see all of them in a couple quick visits, and that it would make a large impact when it comes to buy-in and trying to get that compensation plan implemented. In that process, though, I mean, you gather information, both quantitative and qualitative, typically work through a report and an analysis and try to figure out exactly what's going on, and then you move into the real working group, and that's usually done in two ways. One, you either get a lot of physician involvement and you bring people into a small group of people and work through all the different issues that you found in the information gathering process, and then develop a solution together. That's usually the way that we do things, but it's not to say it's always the way we do things, because in some instances it makes more sense to just go in, and if you find that there really aren't too many problems with the existing model and you're in an organization that moves at a little slower pace and has a model that just kind of needs to be altered a little bit or adjusted for changes in reimbursement, it might make sense to do that without a big working group and just kind of put all of the solution together in one place and then try to communicate that and deliver it to the group of physicians and get it implemented. So those are the two main ways I think that we typically go about the compensation design process, and then actually implementing it. I've been anywhere from just sort of turning the model over to the client and letting them run with it if they're already doing something similar, to actually being on site and working with the quality team and the payroll department and everyone else, and actually, figuring out how we're going to do this and getting it done. And then after all that, I think is where, Stephen, if you want to touch a little bit on strategy and follow up, and then how that turns into sort of just additional assessment.
Yeah, I think the need for good compensation governance is going to depend on how large the group is. Meaning, if a medical group has, maybe 25 physicians, it's going to look much different than if a medical group has 100 or 200 physicians with respect to the level of structure, if you will, governance structure in place. Typically in a health system employed environment, what you have is that the health system board will delegate some level of jurisdiction or oversight of compensation processes and such down to the medical group, with then the health system retaining that fiduciary responsibility for final sign-off and appropriate adjudication, and in terms of a review at least annually, if not more frequently. But with respect to putting a good governance process in place, we frequently will work with compensation committees, a formal compensation committee, and within that there would be some type of a document that defines roles and responsibilities. So what is the role of maybe a chief administrative officer with respect to the philosophy, goals and budgets, recruiting, agreements, policy exceptions, evaluations, those type of things, as opposed to the physician compensation committee, as opposed to maybe a medical group board of trustees versus the health system board of trustees. And so all of those roles and responsibilities should be defined in a good compensation governance context.
Stephen, are you saying that just not everything doesn't just automatically fall in place, and there's no friction between a medical staff and a hospital administration?
Yeah,
that's
exactly.
Crazy thought there, right?
Exactly. To really understand, well, who can approve? At what levels do things need to be vetted? And who has that kind of authority or decision-making process at the committee level? Just need to go to the board of trustees level. Just need to go to the health system level for final sign-off. All of those things would be a prerequisite foundation, we believe, in order to really have a high-functioning comp plan redesign with what I would say is minimal inertia, if you will.
But I gotta think that also helps with things like, just physician. Again, we talked about earlier, physician engagement and transparency and communications, basically making them not only feel like they're part of the process in terms of lip service, but like genuinely making them a part of the governance element that is, ultimately driving what decisions are made and changes if needed.
Absolutely. And, really after you've got a good compensation governance structure in place, it gets down to the nitty gritty, meaning what are the policies with respect to FTE status, with respect to maybe vacation time, with respect to how frequently will we update rates, when can exceptions be made, and all of these type things. If you have a large group, policies become much more needed so that there's not this inherent kind of perception of most favored practice or specialty or special one-off deals that are being done. And so there's real collaboration is what you want to keep within the group. And then, all of those policies could incorporate things like fair market value reviews, commercial reasonableness reviews on an annual basis, some type of audit process, ensuring that compensation paid is tied back to, employment agreements and compensation plans, et cetera. And then as a kind of a third layer underneath, a good committee structure and a good policy structure would be, okay, then what is the plan? And how do we administer that plan in an equitable, in a transparent, and in a way that really a doctor can explain to a spouse on the back of a napkin, perhaps. And that involves a lot of communication, education, and so forth. So a lot's involved in keeping well-functioning, high-functioning compensation plan from an administrative side.
And to touch on two things that both Jon and Stephen spoke to, and I think they're sort of the core is both collaboration and education. I think the key that we have to have as physicians, understanding the why. Meaning, if we're looking at redesigning a model, why are we doing this? What's going on in the market or at our specific health system that is prompting the need to look at something new? And that has to entail a good bit of education to drive that process. And then collaboration as well. What we find is physicians who are involved in the design of the model are ultimately much more accepting of the end result design, especially if they have ongoing input as to its functionality. I think those are key. And it doesn't mean that the physicians ultimately have the final say, that they write their own checks, if you will. But as long as they have a seat at the table, I think it's great. We were talking with a prospective client the other day about the model, and they had just implemented a new model, and it's off the ground, but it's just sort of struggling a little bit. And we were asking about their comp plan governance process and things into that, and they mentioned that they do have a comp committee, but it's all C-level executives of the health system, and the only physician per se on the committee is the VP MA, which from the physician's perspective at the hospital, they saw that individual as more of a hospital executive than a physician. And so, our initial feedback to them was, you may want to step back and look at your governance process, because you may find that the physicians just are more accepting of what's going on if they are part of the compensation committee. And so I think that would be our recommendation, really, at any hospital, is collaboration and ongoing education, and just tailoring that to the size of the hospital that exists, as Stephen, you mentioned.
Absolutely.
Yeah. So are these kind of committees and components we're talking about, walk us through for a second, just again at a high level, but is this going to be, if you think about maybe a employed group, and which over time, depending on the health system, may often involve many different specialties. You got primary care, internal medicine, as well as surgical specialties, other subspecialties. Do you have kind of these groups within each service line, each specialty? Do you have department heads that ultimately feed in, or people that cross over specialties? I mean, just at a high level, walk us through generally what some of those things can look like.
Yeah, I think you're going to want to have your compensation committee reflective of your physician specialties in your network, ultimately, and ideally at with participation by those physician leaders that are respected, so they can really carry the flag back and say, and be a part of the communication process. And so, working with our clients, one of the more effective things we see is where we have a true dyad sort of relationship formed with respect to governance of a medical group. And not just in terms of one position, but there being almost chairs, if you will, of certain, are they medical specialties, surgical specialties, primary care type specialties, maybe an urgent care type thrown in there as well, so that your compensation committee is truly reflective of the environment with which you of your employed group there, and that works well.
Yeah,
if there's good collaboration, of course.
Yeah. I mean, I think that makes sense, and that's probably, obviously, as we said, John, I think you said before, every case is different, so you ultimately adapt to whatever your individual scenario dictates. But I want to kind of continue moving through this process. So we've kind of gone through the design and initial setup. Let's talk about, or continue talking about, the maintenance piece a little bit, or the longer term management piece, and so. Justin, one of the things you, I think, alluded to or kind of used as an example earlier was, I think about some hospitals and systems that are just amalgamating all kinds of individual physicians and physician groups through many different deals, right? And before they know it, after a couple of years, they have 300 employed physicians in their group. Or more, or less. It can be, much less than that and still be significant, but it's typically going to be representative of different specialties as well as internal medicine and primary care. And so there's kind of two things that jump out at me there that really I can see that being a challenge in terms of the long-term management and ultimately maintaining value or increasing value. But first is just the mechanics of trying to consolidate that. So, and you kind of touch on that a little bit in terms of how you approach that. But the other piece is, as we're in a world now where it seems like everything, even within the healthcare management and delivery process, is turning to some degree of automation. So I wonder if there's kind of, what can we do in terms of working within that realm, if anything, in terms of helping maintain, manage, and optimize our comp plans long term, through either technology or automation or whatever the protocols should be.
Yeah, I think that's a great question, great point, Mark. And Jon and Stephen, feel free to chime in on this here in a moment as well. But undoubtedly, compensation models are becoming more complex. I mean, if you think about 5-10 years ago, largely they were just pure work RVU based or collections based models. It's easy, you pull. Well, I shouldn't say it's easy. Some hospitals, it wasn't quite
at least
so
maybe
easy.
Simple, not easy.
Yeah,
there's
fewer moving parts and pieces, and in essence, you extract the production data out of the system and you multiply it by the productivity incentive rate, and there you have it. You have your comp arrangement. And I'm oversimplifying it, but it was a pretty straightforward model. And what we found is over the last few years, as we start inserting panel incentives for primary care, as we start inserting value-based components for all specialties, as just other elements are added to the compensation model, just the model for an individual physician becomes more complex. So what was once a single moving part and piece could be 10, 15, 20 moving parts and pieces and elements, if you will, to the comp model. And if you couple that with the growth in the physician group, meaning maybe it's not 5 physicians, but now it's 50 physicians, you see sort of this multiplying effect of complexity. And what we still see in the industry is so much of the physician comp is maintained in Excel-based spreadsheets, very manual intensive, oftentimes very decentralized in terms of where the calculations are taking place. And we see that changing the market. And Coker specifically has seen this shift, and we see a lot of value in the potential shift, so much so that we've invested in, as everybody on this panel knows, in a company called ProCare Portal, whose sole job as a SaaS-based or software as a service-based company is to automate the physician compensation calculations, to take all of those elements, to pull them straight from the data source, run it through the actual compensation plan design elements, and spit out the end results. And ProCare is not the only organization doing this. I know there's some of the large hospital chains who have created their own internal software strategies, perhaps. And there's other companies out there that have done the same thing. But what we see is health systems realizing that as the models become more complex, as our organizations grow, we've got to do something that is different than this manual process. And in the interim, we've helped, and I know, Jon, you can speak specifically to this, set up some more automated tools to help. But they're still very much Excel-based. They still require a good bit of manual work. And so it's something that we see continuing to evolve in the industry as we look past a very manual process to a more automated process.
And I think, Justin, it's also being driven by the physician's need to want to know their data. Where do they stand? How are they performing? And, if it's on an Excel manual-based sort of platform, that really becomes a bottleneck with maybe 1 or 2 people in the know, as opposed to something that can be more pushed down and accessed at their convenience. So there are multiple drivers to it, multiple benefits. It's not necessarily easy to make the shift, but I think for our health systems and employee groups that have it, they definitely see a lot of benefits, and the physicians see benefits as well.
Yeah, and I mean, I'd echo that, and I'd say it's probably one of the largest challenges I face anytime I try to implement a comp plan, is that you have to try to reconcile what they're currently doing to get the physician's compensation information to payroll with what you've just designed. And gathering all that information in a place that's organized and can be changed, and I would say dynamic, something where you give it a set of inputs and it spits out the right information and can communicate it to physicians and generate reports. And, doing that in Excel, it has its drawbacks. But one of the other things that it has is, whenever you have turnover at an organization, typically there's a lot more education that goes into attempting to get that process back on track as well. Because if, the person who's administering the comp plan at the organization leaves, they have to bring us back in to sort of train and work through that process again and get everyone back up to speed before physicians can keep getting their reports. And that's one of the greatest things about ProCare Portal's design is that it's rules-based. It's the only engine out there that I know of that is rules-based, where you can actually change your compensation plan if, reimbursement changes again in 3 or 4 years. You can use the same software program to retool what you've been doing and, communicate that back to payroll to get physicians paid and generate reports to get them educated and let them know.
Yeah, well, 2 things jump out to me there. And by the way, we're going to have in a future episode, we're going to feature some more discussion specifically from the folks behind ProCare Portal, because I want to dig into the mechanics of it a little bit more, but also kind of why, where the value is. But regardless of the tool you use, I think there are 2 key pieces. One is just from a compliance standpoint, being able to maintain that it goes beyond just the initial fair market value opinion, right? And as we've already discussed. And so the more manual it is, the easier it is, I think, to miss something, let something slip through the cracks, enter something incorrectly, or John, like you said, because of a changeover in personnel or management practices, then, something gets mixed up in the process. The other piece is, and Justin, you teed this up earlier, but as we are moving to more of a kind of value-based realm, if you will, broadly speaking, that means a lot of different things. But if you think about more the evolution, potential evolution, kind of where we're going in a lot of compensation plans, where it is going from purely volume-based metrics to, which even within that, there's a lot of metrics to pull from, as you guys alluded to. But as we start entering or introducing metrics related to quality or attributes that we can use to manage these whether it's time or quality or outcomes or savings, whatever kind of, however you want to define value, that's only become more important. And so the inputs, I feel like, are becoming more complex, or will eventually become more complex as well. As we kind of wrap up, what I'd like you guys to do, if you don't mind, maybe just real quickly walk us through you don't have to do like a full case study here, but I think people would be interested in knowing, okay, what can this look like? What are some of the key steps? What are some of the things to look out for, but, maybe putting that in the context of things you guys have seen and done with clients today. Is there anything you can think of there, either anecdotally or, very specific in terms of, where kind of we've been able to kind of interject ourselves and create value in this process?
Yeah, I'll make a couple comments, and I'll ask Jon and Stephen to provide any final comments they want to make. But it goes back to a comment I made earlier, which is we see the comp models as being living and breathing. And so if you're not looking at your compensation model regularly, it would probably make sense to do so, just to make sure that it continues to be market-based and relevant. The other thing I will caution, though, is there's so much talk about the value-based movement right now. And I think absolutely it makes sense to start tweaking the model to incorporate the value-based elements. But just because we're moving into a value-based realm doesn't mean that we need wholesale change in terms of throwing out all production-based metrics and only focusing on outcomes or quality-based metrics. If you use MIPS as an example, which is pretty much affecting the majority of providers out there that take Medicare, MIPS is still very much a volume-based reimbursement scheme, but it is volume with strings attached, meaning your reimbursement will be impacted if you don't meet certain quality metrics as well. And so I would just caution to say, take a step back, think about what's driving reimbursement in your market, and let that be sort of the initial step that you're taking in terms of how radical of a shift you need with respect to your compensation arrangement. And so inevitably, we've got to start taking into consideration these value-based elements. But in a lot of instances, it can be minor tweaks versus wholesale changes.
Yeah, probably a slower evolution as opposed to some sort of overnight shift, I think makes sense.
Absolutely.
A large percentage of these plans is still productivity based.
Yeah, I agree with all that. And, I think one of the places where I think we add a lot of value as a firm is just in our methodology and our breadth of expertise, because our methodology, I feel, is very comprehensive, very holistic. We dive into organizations and we ask a lot of very basic questions: the why, the how, the what, the when. We really get down to all of that, and we get down to the real pain points in our clients' lives and try to figure out how we can help them through that, solve their biggest problems and really get them moving forward. And sometimes that leads to things that are outside of compensation design, where you find the biggest issues aren't really even based on what they hired us to do initially, but it's still part of it. And I think that that's a really important thing about our approach. And the other thing is that we work in every different type of market, because I think being experts in rural hospitals and metropolitan areas and everywhere in between is something that really kind of sets us apart and makes us capable of solving any problem.
I echo those comments as well, Jon and Justin. And I would just add in closing that I think we add a lot of value as well in creating something, a comp plan that's adaptable to where the hospital, where the medical group wants to go. 3 years, 5 years, what's the vision? And so it's not going to necessarily entail, a revision every 2 or 3 years, but rather maybe slight adjustments that are already pre-planned at the beginning. And so that sort of long view, I feel, really adds a lot of value to our clients, in that they can be self-sustaining and we can be truly an advisor to them, as opposed to maybe needing to come in and do some type of radical change at some point in the future.
That's great. Obviously, we've covered a lot of ground here, but this has been, I think, extremely productive and informative. And again, we're going to have multiple subsequent discussions diving a little bit deeper in some of these areas. So you guys will be hearing more from Justin and Stephen and Jon in the future for sure, as well as others. Also, I just want to remind everyone, as we mentioned in the intro, that we'll have a few kind of supporting documents, some white papers we've written on this topic, and a couple other things that people can download and kind of get a little bit more detailed context. Obviously we welcome questions and suggestions if there's something specific you'd like to hear about as it relates to comp or anything else. But Stephen, Justin, Jon, I appreciate you all participating, and we look forward to talking in future episodes.
Yeah, great. Thanks.
Thanks a lot.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We'd love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.